Today's video is for men who have been to their family physician, have had a digital rectal exam, and were told that they have a bump on their prostate, but they haven't had their PSA results back. We want to talk about the context of what the bump could mean, what their PSA results could come back as, and how to kind of interpret those results, and also what the next steps would be after being told that there is a bump on your prostate, your PSA is high, what now? So today we're talking to Dr. Mark Schulz. He's a 30-year medical oncologist who is focused solely in prostate cancer, and we're going to find out more about this process. So in today's video, we are talking about a situation in which a man goes in for an annual physical and he gets a digital rectal exam, which is a finger exam in his rectum, and they're feeling his prostate. They can only feel the one side of the prostate, but every once in a while, a doctor finds a bump and maybe they're having their PSA ran at the same time, but they're not going to get those results back right away. PSAs can take anywhere from 1 day, 24 hours to a week. And so now the man is told there's a bump, and that can cause a lot of anxiety. So I thought today we could talk about clarifying the situation. We could talk about how prostate cancer acts in general, and make sure that we can kind of give some context to what the bump could be, and maybe give some peace to people who maybe are going to the extreme thinking of, oh no, I have the worst cancer, versus how prostate cancer can act in 50% of all cancers, being Gleason 6, which will not metastasize. So within that context, can you kind of walk us through the process in which someone would get a digital rectal exam?
Interestingly, digital rectal exams have been performed with less frequency in the last probably 10 years with the advancements in imaging and the utilization of PSA, which is, it's easier to talk patients into doing a PSA than a digital rectal exam. Although we're running into this less frequently, digital rectal exams are sometimes done when people go in for a colonoscopy. The gastroenterologist will check people. It is still a good policy because there are types of prostate cancer that don't make a lot of PSA, and actually those potentially are the more dangerous variants. Something could be detected on a digital rectal exam even though the PSA is still in the normal range. So it is a good policy for people who are just getting an annual physical exam to have a digital rectal exam to see if there's an abnormality that could be prostate cancer. We have to be careful here because there's a lot of bumps and abnormalities felt on digital rectal exams that aren't cancer. People can have prostate stones, for example. They can have scar tissue from previous infections. And people come with different sizes and shapes of prostates. And family doctors who are doing these digital exams may just say something doesn't feel right. It may not even be a bump. It's a reasonable policy as part of the physical exam to do a digital rectal exam. They're not very precise for detecting prostate cancer, but it's sort of a fail-safe. Some unfortunate individual had a type of prostate cancer, one of the more aggressive ones that doesn't make much PSA. You could detect the cancer earlier with a digital rectal than you would with the PSA test.
So for those low PSA-producing cancers, what percentage of them are they in all of prostate cancer?
It's a very small percentage. I would say of the 200,000 men that are diagnosed every year in the United States, it's going to be less than 5%, maybe less than 2%. But those are potentially the cancers that can give prostate cancer a bad reputation. We're always talking down that prostate cancer isn't that serious, it doesn't spread easily, it's easy to cure now. But there are these very, very small segments that are more aggressive, and sometimes they will be detected with a digital rectal, even when the PSA is normal.
Before I get to my next question, I just wanted to let you know that we do have an in-person prostate cancer patient conference coming up in September, and it's a great way to get your questions answered by world-renowned physicians in person. Also, don't forget to click that subscribe button because we come out with new videos like this and on men's health every week. And if you would like to support us financially, you can do so at pcri.org/donate. Now back to my conversation with Dr. Schulz. So with that low percentage, I've heard the argument that most doctors are now just giving PSAs and not doing digital rectal exams at all. It seems to me like both would be prudent no matter what. So should men who haven't been checked be asking for a digital rectal exam if their doctor just suggests a PSA?
Yeah, that'd be great. I think the issue, of course, is that it's hard to get men into the doctor's office anyway, and if we're threatening them with a digital rectal exam, they might not even come in and get a PSA. And the PSA is a far more powerful and certainly more accessible test. If the digital rectal is going to frighten people away from the doctor's office, let's at least get a PSA. You see a profile of clientele, people that want to be very thorough about their health, and I think this is wise. Our health is our most valuable asset. It is a little unpleasant to go through a digital rectal exam, but it can occasionally uncover something that you want to know about and catch early.
We deal with a lot of patients who have been newly diagnosed or kind of going through this process with Helpline. And one of the most common questions is, okay, so if they found a bump and my PSA was higher than normal ranges, what do higher than normal ranges mean? So can you kind of explain the PSA range of what would be considered normal?
Well, sophisticated people ask their physician after he's done the digital rectal exam, do I have an enlarged prostate? Because men with bigger prostates are going to run higher PSAs just because their gland is bigger, not because of cancer. That level of sophistication is very rare, and more commonly, you'll get the report back and it'll have an upper limit of normal. It may be 2.5 with certain assays, it may be 4.0 with other assays. It's unfortunate that people look at that as just a raw cutoff. For example, if your PSA is 2.4 and you're 40 years old, that would be a very worrisome sign. Men that are in their 40s should probably have PSAs under 1. Enlargement of the gland over time causes the threshold of normalcy to go up with time. Really, we don't want to be relying just exclusively on one number. If men are getting PSAs done every year and their PSA is rising, that may need some attention. It's not a fixed target, unfortunately.
So if a man is getting a digital rectal exam and the urologist says that he feels a large bump, which we've seen in some of the Helpline comments, does that automatically mean that it's cancer?
No, it does not always mean that it's cancer. I think the next question would be, well, what's the next step? Historically, it's been a random biopsy where they go around the clock with 12 random sticks with a large bore needle into the prostate through the rectum. That, I think, is unfortunate. I really passionately believe now that MRI technology, imaging technology has gotten so good that the next step should be an MRI. And that accomplishes two things. One is it takes some of the responsibility out of the hands of the urologist. The urologists are surgeons, and their viewpoint and attitude towards any kind of cancer is let's operate, which has all kinds of negative repercussions that we won't go into here. But if you have an MRI and the MRI looks suspicious and confirms that it does indeed look like a probable cancer, then the option of having the urologist do the biopsy or consulting with an interventional radiologist at a hospital to do a targeted biopsy of the abnormality then takes some of the responsibility out of the hands of the urologist and puts the power more back on your own shoulders.
With this situation, we find men who are then waiting for their biopsy results, and then they're looking at, Gleason scores. They're starting to educate themselves on what the possibilities could be. Now, if they get a random needle biopsy or a targeted biopsy back, and it says that they do indeed have prostate cancer, can you just walk us through the ranges of the different types of prostate cancer? Because I think a lot of men oftentimes in this situation get pushed to surgery very quickly because any presence of the word cancer comes up, and then that's the standard of care when it comes to the urology world.
Right, and as I've already said, I don't really think as of 2025 any man should be doing surgery for prostate cancer. There are too many other more sophisticated options, usually in the radiation realm. The types of cancer are a result of both staging and the biopsy results themselves. So there's a 1 through 5 scale that was developed by a guy named Jonathan Epstein, which is very useful. There is a type of prostate cancer, level 1, and this is about half of the men that are diagnosed every year, maybe 100,000 men, that never spreads and should be considered a benign tumor and doesn't need any treatment. A certain percentage of the level 2 cancers can be watched as well. And this is something that is not widely understood throughout the prostate cancer world. Oftentimes, anything above 1 is presented to patients as an absolute need for immediate treatment, that it could be deadly. And of course, some of the level 2s should be treated. There's a big range of level 2s, of favorable ones to unfavorable ones. And the favorable ones often can be watched with a very reasonable degree of confidence. And then when you get into the unfavorable 2s and above, then you're talking about implementing some sort of treatment.
So in the context of the Gleason scoring system or the Epstein system, you're talking about pathological staging, but there's also clinical staging. So, how big the bump feels on that digital rectal exam. So how do, the physicians, how are they weighing this? What does a patient need to know in order to put that into context so that they can, take care of their health and first do no harm from the beginning?
This was more important before we had MRIs, and with MRIs now we can look at how big these tumors are, and it is well known with all cancers, including prostate cancers, that as the larger they get, that the statistical possibility of spread outside the gland also goes up with size. And so clinical staging was very important before we had MRIs, where the doctors would feel a bump in relation to the size of the gland. So if the bump was less than a quarter of the size of the gland and on one side, that would be clinical stage T2A or an earlier stage. And the next level is where if the bump would start to cross over to where it covered 2 quadrants, and that would be a clinical stage T2B. And then if the tumor or the bump starts crossing over the midline, so it's on both sides of the gland, that would be considered a T2C. And then if the doctor thought that the cancer was growing out the edge, that would be called a T3 or T3B if they thought it got all the way up into the seminal vesicles. This still has some relevance in the modern world, but we're not talking about that as much given the precise MRI information that we have. And of course, pathologic staging, clinical staging in the old days was profiling people to try and project the possibility of microscopic spread. Now that we have PSMA PET scans, we can actually look for spread, and we have much more confidence about the presence or absence of spread based on a scan rather than a profiling system that was developed 30, 40 years ago.
So we have varying situations. We have people who are going to community settings. We have people who are going to large universities. We have people who watch these videos that are in, international, places. They're all over the world, and they need to advocate for themselves in order to make sure that they're getting the imaging first before they get a biopsy. So can you kind of talk about what that process is like for a patient to really request imaging before and how they advocate for themselves?
For patients, especially ones that haven't been in the medical world, maybe they haven't had anyone sick in their family before, it's a new thought to start telling your doctor what you want. There's a whole new vocabulary, there's a lot at stake to get it right, and it's very natural to just delegate it to the doctor, who's no doubt hopefully has your best interests at heart. The problem is that the system has become so powerful and so specialized that it is very common for certain doctors to have an agenda that will fit within their purview of what they do on a regular basis, and it won't be as broad a view. Many of the doctors, the urologists, are still not even doing MRIs, and that is a very unfortunate thing. Patients do have to get outside their comfort zone and realize that they're going to have to take control, get online, learn about prostate cancer, and respectfully but firmly show their physicians that they have a say in this process and they want to understand it, and they don't want to be simply told what to do. After study, they're going to learn that there may be a better way.
I think in the context of this video, especially for people who are new to this situation, can you talk about the importance of second opinions, not only with physicians, but getting secondary checks on PSA and secondary checks on pathology reports as well?
I think what you're alluding to is that it's not only the physician that's sitting in front of you. You have to judge their quality, their experience, and this is, of course, very important because big decisions are going to be made, and there are different skill level physicians out there. But all the information that you get through reports or scans or biopsies is filtered through other physicians of varying ability and quality. So cross-checking those things to make sure that the information you're getting is accurate. Think how relevant it would be, as we talked earlier, that if you have a level 1 pathology, you can simply watch it. But it is possible for doctors to look at a level 1 and through lack of experience or through making mistakes, call it a level 2 or a level 3, which then triggers this whole treatment mechanism when it would be perfectly safe, when in reality you had a level 1, to watch it. So these things can be cross-checked and sent out to reference centers to make sure that the information is accurate.
Going to the doctor, getting your annual physical, getting a digital rectal exam, and then being told that there's a bump on your prostate without having PSA results back right away is a very uncomfortable situation. But I want to commend you. Thank you for taking care of yourself and getting checked in the first place. This early measure to take care of your health and get screened is so important. Now, I want to tell you about a couple things that I suggest people do when they're in this situation. First of all, talk to somebody right away that is going to be in your corner, somebody just to let them know what's going on and get emotional, mental support through this process. They can help you research, they can go to your doctor's appointments with you. I think men kind of wait till there's like a diagnosis of cancer before they bring someone in, but we found that earlier is better. Also, 50% of all prostate cancers are not a type of cancer that will metastasize. So that's good news. I think another thing to do is just do your research and see where you can get a targeted biopsy versus a random needle biopsy, and make sure that you advocate for yourself. Call the insurance company, see if you can get imaging ahead of time. And even if you don't have a doctor who's willing to work with you on that, maybe get a second doctor who would be willing to work with you. Taking time to do your research can be can take a lot of anxiety away, but it also can help you get through this process a lot smoother. Now, all prostate cancer is slow growing, but the good thing to know is that you have time. And the time is important because you have time to do the research. It's okay if the PSA is taking a little bit to come back. It's not going to alter the state of where you're currently at. A week isn't going to change. I think that's a question we get a lot of times is, if my PSA results were taken a week ago, how much can it change? It's not that big of a difference, and I think that's an important thing to note. And make sure that you write your questions down ahead of time when you go to the next appointment and you want to talk to your doctor. All of these things can help with anxiety, they can help with mental health, and they can help you in the waiting process. You can do more research on our YouTube channel here, and go ahead and subscribe because it's just a good way to stay up to date on these things as you get older. We cover a lot of other men's health and screening and checking that is really important for you to do. And you can even talk to our helpline. These are prostate cancer patients who have been treated and diagnosed, but they've gone through this whole process. They've had digital rectal exams, they've had elevated PSAs, they know what it's like to go to the doctors and have to, kind of advocate for yourself through this process. And they're a great resource. You can find them at pcri.org/helpline. Now, please remember that you're not alone. Get the support you need, take care of yourself. We really appreciate you, and I hope you have a great week.